Hello, I am Joan Gornals from Hospital Universitari de Bellvitge, University of Barcelona and Bellvitge Research Institute. I am honored to share our study recently published in gastrointestinal endoscopy. Now I would like to introduce my colleague, Francesc Bas-Cutrina, and together we will explain you the reasons to do this study and the results.
Hello, I'm Francesc and I am a Physician Research Fellow in Dr. Gornals' team. I am also glad to introduce you the results of our study. But firstly, Joan, what are the main reasons to do this study?
To sum up, the reasons were: first, for small-sized subepithelial tumors of unknown histology, current international guidelines usually recommend periodic surveillance. And despite endoscopic resection may be an option, it may associate considerable adverse events. Second, even though most subepithelial tumors are benign entities, in 20% of cases there may be a potentially malignant lesion. And lastly, evidence of endoscopic banding without resection in the management of these small tumors is scarce and limited to retrospective case series. An initial experience in our unit with this technique, firstly in small and superficial lesions, and secondly in lesions with deep layer dependency, encourage us to design a prospective and observational study. Okay, please, Francesc, could you explain us the objective and the design of this study?
Definitely. The aim was to evaluate the feasibility of this endoscopic strategy in small subepithelial tumors management. This was a prospective multicenter observational study conducted in 7 Spanish centers. All cases include where small-sized tumor, it means less than 15 millimeters, with an echo pattern that did not allow exclusion of a potentially malignant lesion by UES, mainly a solid and hypo or iso-hypoechoic pattern. Therefore, vascular lesions or clearly benign lesions, lipomas, pancreatic rest by US image were excluded. And the primary outcome was clinical success at 4 weeks, defined by complete subepithelial tumor disappearance at first US control. Regarding follow-up, after evaluating the technical success in the initial endoscopy, we contacted the patient at 24 hours and 7 days by phone call. We repeated the UAS at 4-6 weeks and in 1 year to assess the clinical success. Here you can see the image sequence of a successfully case performed.
Thank you, Francesc. And now could you advance us the results of this study?
Of course, Joan. A total of 273 patients were screened, and finally 122 subepithelial tumors were included, with a mean size of 9 millimeters, and most of them were gastric lesions. Regarding the primary endpoint, it was achieved in a 73% of cases. At 1 year follow-up, success rate was 68%, and the favorable clinical impact was observed in 79% of cases. Pathology diagnosis was known in 70% of cases. Potentially malignant lesions were present in 24%, including neuroendocrine and gastrointestinal stromal tumors. Regarding safety, we observed a total of 6 adverse events, representing a 4.9%, all of them mild ones. 5 relate to the technique and 1 not related to it, 1 aspiration pneumonia after sedation. On multivariable analysis, lesions less than 10 millimeters were associated with a greater success rate, 87% at 1 year, and with a clinical impact rate of 92.7%.
And to conclude, what this study really adds?
In conclusion, this strategy proposal seems to be safe, effective, feasible, and acceptable in the management of these small subepithelial lesions. Endoscopic banding complemented with a zinc biopsy offers an overall favorable positive impact, and lesions less or equal to 10 mm with superficial dependence are the best candidates. On the contrary, this technique is not the most suitable for cysts over 10 mm and those with deep dependency.
And lastly, how this study may affect research and clinical practice. In our opinion, this study provides new and relevant information regarding the management of small subepithelial tumors, not included in the latest guidelines, offering a possible solution which may be considered in the daily clinical practice and may alleviate patients from never-ending surveillance and worry.
Just that in all cases with a pathology diagnosis of potentially malignant lesion and all non-diagnostic lesions, the surveillance is having continued until to complete 5 years of follow-up.
We will be grateful to share with you a next study with this long-term follow-up. Before ending, we would like to thank the Spanish and the Catalan societies for the help to carry out this project.
Thank you very much for your attention.
Thank you and regards from Barcelona.